So it's a real honor to be invited to speak at your esteemed online conference. I had the pleasure to listen to a few of the lectures that are online, and I was really amazed by the quality of speakers that you have invited. And I feel very honored to be a part of that lecture series. Today, I will talk about the management and management principles surrounding brain arteriovenous malformations. I perform consulting and proctoring for a number of endovascular companies, but none of those are presenting any conflict of interests to this talk. Now, just a little bit about my background. Since 2021, I'm a professor and chair of the Department of Neurosurgery in Salzburg, Austria. And what is quite unique in our shop is that we have an established practice of hybrid cerebrovascular neurosurgery. We currently have 5 cerebrovascular neurosurgeons that are all trained in endovascular techniques as well. And we perform open and endovascular treatment of aneurysms. We're also involved in the surgical management of stroke thrombectomy. We do bypass surgery, and obviously we manage patients with brain AVMs. And I want to start off with one of my most recent AVM cases. This is a 33-year-old female. She came in with epilepsy already more than 10 years ago in 2011 and was found to have a right frontal arteriovenous malformation. And at the time, she was treated in an outside hospital with partial embolization and then followed up with gamma knife. And she was kept being followed. And then on the most recent angiogram last year, she had persistent filling of that AVM. Let me see. Okay, you can see the pictures here. Typical right frontal AVM, NIDA size between 3 and 6 centimeters, non-eloquent, and superficial venous drainage consistent with Spätzle-Martin grade 2 AVM. Here you can see the angiogram on the frontal and on the lateral projection. So what did we do? Since she had basically failed endovascular and radiation treatment, we decided to operate on her. We went on to partially embolize the AVM. Now, you could argue that this is one that you could just straight up operate as well. But since we are quite familiar with embolization, we like to embolize in some cases just to decrease the flow through the AVM. What we also attempted was to get hold of this deep perforator. It's a perforator arising from the A1, and anybody who does AVM surgery knows that it can be sometimes tedious to manage those perforators coming through the white matter. They can be squirting little red devils, is what my mentor, Dr. Ogilvy, would call them. And sometimes they retract into the white matter, and it's difficult to control them. Now, what the challenge to embolize that feeder was that when you come up from the ipsilateral carotid artery, you would basically have a 180-degree turn from the A1 into that small perforator, and we were not able to negotiate that with the catheter. So what we did is we thought about, okay, well, let's not come ipsilaterally, let's come from the other side and go across the intercommunicating artery and get into that branch this way. You can see it here. When you come from the contralateral side, you come across ACOM, then basically it's a straight shot and there's not a 180-degree turn. We end up being able to get into it, as you can see here on this microcatheter run, but we were still, in my opinion, too distal to really safely embolize that. So we actually chose not to embolize from that feeder. So here you can see the final result of the embolization stage. And then what I've started doing is I really embolize and operate in the same setting. So I go basically straight from the angio suite to the operating room. We currently don't have a hybrid suite, but if we did, it would make it even easier. So we don't delay surgery, we do embolization surgery in 1 day. Here you can see ICG angiogram. I think it's very helpful to do an ICG when you start AVM surgery right before you do any kind of surgery, just to get a good understanding of where the feeders are coming from and at what sequence the veins are filling. There's a few intraoperative pictures here to the left where you can see the AVM nidus with the large draining vein along the superior sagittal sinus. Then the principles of AVM surgery is that you work your way around the nidus. You can see cotton patties push down along the border zone of the AVM. And then here in that piece, you can see that little feeder that we had intended to embolize, but weren't able to get to, where we were able to handle that easily with just bipolar cautery. And then we like to do intraoperative angiogram. And here you can see there is delayed filling of that MCA, large MCA branch, but the AVM is completely obliterated. This lady had an uneventful postoperative course, made a great recovery, and was eventually discharged home neurologically intact. So my personal journey in terms of AVM management has been interesting. When I was a resident at the University of Alabama in the United States, essentially all AVMs were radiated. They were treated with radiosurgery. I saw very few AVMs in my training. And then I went on to do a cerebrovascular fellowship, and I moved from Alabama to Boston and trained with Chris Ogilvie and Ajit Thomas. And there, most AVMs were managed with surgery plus minus embolization. So even within the same country, there is significant differences in how AVMs are managed. I currently adopted a practice that's very similar to one in Boston. We do operate AVMs, preferably if possible. We operate between 8 and 10 AVMs per year, and we mostly do surgery. And like I said, we tend to do, if we do embolization, we do immediate embolization, then do surgery right after. We do send some people for radiosurgery as well if they are deep-seated and not amendable for surgical resection. Now let's talk about AVMs in general. So we know they're about as 1/10 as common as intracranial aneurysms. The prevalence is somewhere around 0.6% at the most. We know that the hemorrhage rate per year on average is somewhere between 2 and 4%. Now, this hemorrhage rate varies significantly with the angio-architecture of the AVM. And when you have had a previous hemorrhage, the risk of hemorrhage per year goes up to about 7% per year. As you all know, AVMs are vascular malformations that are missing an interspersed capillary bed, and there is a straight arteriovenous shunts. Now, not all AVMs are the same in flavor. So here you can see all different AVMs, from a right frontal Spätzle-Martin grade AVM to one that's small but in an eloquent location, one with deep venous drainage. And then as they go, they become more and more complex along the Spätzle-Martin classification to where they are Spätzle-Martin grade 5 with deep drainage, large, all eloquent areas, basically AVMs that we don't really have any options to treat for. But not all components of AVM characteristics are captured within the Spätzle-Martin grade. You know, it can be PL supply or even sometimes supply from the meningeal arteries. There is feeding vessel aneurysms that develop. We currently have a patient that we treated very recently with a large AVM. She has so many feeding vessel aneurysms that are too numerous to count, and she had subarachnoid hemorrhage from one of those. Really, the treatment in that case is to treat the AVM, which is triggering the feeding vessel aneurysms. When it comes to AVMs, it's very critical to understand en passage feeders, meaning it's just a feeder that goes just to the AVM, or does it give off vessels that go and supply regular brain? Here, as shown earlier, it matters whether there is deep perforators that come to an AVM, whether the nidus is compact or diffuse, as here seen here, whether the nidus is completely in the brainstem, like as it is shown here, one that's completely inoperable, obviously. And then there is a disorder that's sometimes confused with AVMs called cerebral proliferative arteriopathy, which I'm going to talk about on the next slide. Now, this is a disease that is thought to be related to ischemia. It's different from AVMs that they are usually large in size, lobar. They have no dominant feeders or aneurysms. Sometimes stenosis of the feeding arteries, which leads to the assumption that they are secondary to ischemia. They have no AV shunting, which is the main characteristic, no large draining veins, and there's normal drain between those vessels. They're preferably in young females, and they can cause seizures, hemorrhages, headaches, stroke, but they're not AVMs in the classic sense, even though on angiography, on the first glance, as you can see in those pictures, they look like an AVM. In terms of morbidity and mortality, AVMs are not as dangerous as ruptured aneurysms. We say that about 20 to 30% morbidity with hemorrhage. The mortality is around 5 to 30%. And people with AVMs have a risk of developing seizures and epilepsy, and the incidence is between 1 to 4% per year. In total, about a quarter of all AVM patients present with seizures. Now, what do we know about the pathogenesis of AVMs? And there's been a recent paper in the New England Journal of Medicine where KRAS mutations, which is a mutation that's seen in various cancers, have been found in a number of tissue samples from patients with brain AVMs. And they've really identified 3 gain-of-function KRAS mutations, mostly this GLY12A ASP and GLY12 VAL, that's been found in less than 5% of DNA sequences, but interestingly, none of those mutations were found in the blood of those patients. And we think those mutations are specific to endothelial cells. They appear during embryogenesis, and they dysregulate vascular morphogenesis. Now, what is different from these mutations to tumors, for example, is they are not coexistent with other driver mutations that you see in cancer, just as TP53. And there's a number of pathways that are being activated with this gain-of-function mutations that contribute to the development of AVMs. And what is interesting is that from the cancer literature, there are specific medications that target KRAS. One is the sotorasib, which is a KRAS inhibitor, which has been shown to work quite well in the treatment of facial AVMs. Now, I've not found anything on cerebral AVMs. I think blood-brain barrier penetration may be an issue. It's also a slightly different mutation that this inhibits than that one was found in the brain, but it's certainly one promising aspect of potential medical treatment for AVMs in the future. You can see here, these are those patients from the New England Journal of Medicine paper. And in the first graph, every patient with one of those orange columns had mutations in one of those KRAS genes. So in total, about 2/3 of AVM patients had mutations in cells in their AVMs in the KRAS gene. Now, when we talk about AVM, obviously we are worried about AVM rupture. It's where the morbidity is coming from. And at Johns Hopkins, a few years ago, they developed this R2ED AVM score, which is supposed to predict the likelihood of rupture of a brain AVM. When we talk about Spetzler-Martin classification, we know about its surgical morbidity, but it doesn't say anything about the likelihood of AVM rupture. And these were the factors that they identified, a non-white race, exclusive deep location, small nidus size, venous drainage exclusively deep, and monoarterial feeding. All these factors are higher risk for rupture. Why is that important? Because when you counsel a patient, it's not just that they are known to have an AVM. You also want to estimate what is the risk of rupture. And we actually validated that study with our group of patients at Geisinger, and we found that the validity of that study is there, and the higher the score is, the higher the chance of having presented with rupture. Now, this is a score that's obviously developed retrospectively, so it's not a prospectively validated score. So it's not that we can really extrapolate it, we can make predictions, but it certainly gives some idea of which AVMs may be higher risk for rupture. How do we manage AVMs? I think the surgical resection of AVMs remains one of the main treatments. When we talk about surgical risk of AVMs, we cannot, pass by the Spätzler-Martin classification. I actually had the pleasure to work with Neil Martin at Geisinger. He was the neuroscience chair for a few years when I was there. I've met Dr. Spätzler a few times. I know he has been presented to your department as well. And Spätzler-Martin looks at AVM size, eloquent location, and venous drainage. And the higher the score, the higher the risk of morbidity from surgery. Now, from my point of view, size is obviously very relevant because AVMs need to be essentially resected en bloc. It's not that you can take it out like a glioblastoma or metastasis where you can do piecemeal resection. You have to do it en bloc resection. The bigger the size, the more challenging it gets. Of all the factors, I think eloquence to me is by far the most important one. An AVM that's in clearly eloquent cortex is one that is probably not ideal for surgical resection. The pattern of venous drainage to me is not so relevant. Sometimes deep venous drainage actually gives you a good access to the AVM from operating, vertically towards the tip of the nidus. However, I've seen one case where an AVM was primarily draining in the deep venous system, and with the AVM being resected, there was significant decrease in the venous flow in the deep venous system, and it led to thrombosis of the deep venous system with significant morbidity. So that's another aspect to consider. It's not just the accessibility of the vein, it's also the AV shunting into the deep venous system. We have then seen iterations of the Spätzler-Martin classification. Spätzler then combined 1 and 2 and 4 and 5 and classified them as A, B, and C. And basically the recommendation is for A and B, you prefer resection. 3 is multimodality treatment, and 4s and 5s should, if preferably, not be treated. We have looked at the Spätzler-Martin classification, the Spätzler-Pons classification to see how reliable are neurosurgeons in classifying those AVMs. And you can see those numbers. Those are reliability numbers. And the higher the number is to 1, the better the scale is. And what is interesting is that when it comes to eloquence, at least on the first go around, people were not even agreeing very highly on whether an AVM was in an eloquent location or not. So it's not so easy to actually grade eloquence on AVMs, apparently. In terms of 5-tier Spätzler-Martin and 3-tier Spätzler-Pons, the overall reliability was quite the same for both scales. And then Neil Martin and his group at UCSF came up with a modification, or I would say extension of Spätzler-Martin, which is the Spätzler-Lawton-Young classification. And in the same scheme, he added 3 additional factors. He added age, less than 20, 20 to 40, and greater than 40, with higher age being higher risk. Whether the AVM has bled. AVMs that have bled are usually much easier to resect because you have a bleeding cavity that has already created some cavity through which you can easily access the AVM nidus, and whether the AVM is compact. The more compact it is, the easier it is to resect and the less morbidity there is. And you can see that, at least in their cohort, the area under the curve to predict outcome was even better with the supplemental than with just the Spätzler-Martin classification. And like I said, previous hemorrhage has really a positive impact on resectability of AVMs. These are a couple of like classic AVM examples from my point of view for just pure surgery. These are Sylvian AVMs. You can see a previously ruptured AVM. There is a lot of en passage feeders coming from the M2 middle cerebral artery. These are ones that are not good for embolization. They are ideal for resection. Here is two Sylvian AVMs that I've operated in the last years. I've really come to appreciate those irrigating bipolars. I really like those. Ever since we have those, we rarely use AVM clips. They are very good at taking care of those AVM arteries and closing them off. This is another Sylvian AVM right here, or the Sylvian fissure, also presented rupture, also treated with primary surgery. And here is an interhemispheric AVM, also with a clot, also treated with surgery here. So those, I think, are great examples for surgical AVMs. Another nice one that I have done a few years ago was one in the cerebellum, in the petrosal fissure, coming down, opening the petrosal fissure down towards the trigeminal nerve, opening the petrosal fissure, and then resecting this previously ruptured AVM through a retrosigmoid craniotomy. So another one that I think, is not a good candidate for embolization. That's very ideally managed with open surgery. So these were some examples of AVMs that you just can straight up operate on. Now let's talk a little bit about embolization. The two main embolizates I have experience with are superglue or NBCA and onyx. You can see a few facts about these adhesives here. I really have come to use only onyx. I don't use any NBCA for AVMs because onyx gives us the luxury to inject over a much longer time. With a glue, you have to inject very quickly, and as soon as you get reflux, you have to pull the microcatheter out because otherwise you could glue your microcatheter in. That's not as big of a problem with onyx. So we generally use onyx 18 or 34 for preoperative AVM embolization. When we look at AVM embolization, we know it's not very safe. And it's different factors that matter for the risk of embolization than for surgery. And the group from Buffalo has published this classification scheme where they assign points similar to the Spätzle-Martin classification with the risk associated not with resection, but this time with embolization. And what you can see here, obviously, is smaller feeders are higher risk for embolization, eloquent location, higher risk for embolization. But what you also see is that in their series, only 10% of patients were just treated with or were just cured with embolization only. And this is another meta-analysis looking at different embolic agents and morbidity associated with embolizates. And you can see in the similar as in the Buffalo study, the occlusion rate just with embolization is relatively low. I mean, certainly not high enough of what we would expect from a successful AVM treatment. One of the, I would say, most experienced interventionalists embolizing AVMs is the group from Ankara, from Turkey, and they have, published their experience, and at least in this paper from a few years ago, their cure rate was around 50% with embolization, still much higher than anybody else basically in the world, but still much less than what we achieve with surgery or other modalities. And what has been interesting is this, what they published last year is this called multi-plug flow control technique. I don't really know a lot of centers doing this. We certainly haven't done this yet, but basically their philosophy is that they sometimes embolize from 3 or 4 different feeding arteries simultaneously. And this is a paper in JNIS that, like I said, was published last year where they present this technique. They haven't published the data yet, but at least they claim that with this technique, they have an greater than 90% occlusion rate. I don't know if you have seen patients from this center in İzmir, but it's certainly an interesting technique, but I haven't really had any hands-on experience with it. So the third main treatment approach is radiosurgery. And either you radiate with photons through gamma knife or LINAC. Generally, you radiate with about 20 gray to the 50% isodose line, or alternatively, we can radiate with proton beams. Now, we have one proton center in Austria. We use them a lot for skull-based tumors. I've not sent them any AVM patients yet, but it's also a modality that has been considered for AVM radiation. And some of the best data are coming from UVA and that center in the United States. And you can see they get obliteration rates with radiation around 60, 65% on average. Obliteration rate obviously goes up with time. So initially you have no obliteration, and with 3 to 4 years, you tend to reach around 70, 80%. Better odds with smaller AVMs, non-eloquent, and at least in some series when there's not been any prior embolization or hemorrhage. But the rate of radiation-induced changes should not be underestimated. I mean, I've seen a number of AVM patients who have been radiated who came back later on with symptoms due to radiation-induced changes. Now, what do you do with large AVMs and radiation? You can either do volume staging or dose staging. Volume staging means that you break up the AVM in multiple compartments and radiate each compartment sequentially, or you dose stage. You give each individual dose or each individual treatment a lower dose, but you treat the AVM in multiple sessions with lower dose in each. And there's a nice meta-analysis that's been published, I think, in JNS. And even here, you can see with volume staging, you get an obliteration rate around 40%. With dose staging, it's even less, 30%. But the morbidity with volume staging is higher than with dose staging. But you see still obliteration rates far from what we would consider acceptable. Now, granted, those are large AVMs, but still not a satisfactory obliteration rate. So what about combined treatments? I started off earlier talking about preoperative embolization. What's the reason to preoperatively embolize? You may want to reduce the AVM volume and downgrade AVMs, so decrease the amount of shunting. You can very specifically embolize feeders that you know that are very difficult to reach. Like, for example, if an AVM is supplied by superior cerebellar arteries or maybe by deep feeders from the anterior cerebral artery, you can get targeted embolization just for feeders that are difficult to reach surgically. And the whole idea that the AVM that's perfused less will result in less blood loss and less operative time. And I want to make you pay attention to this study called the TOBA study, which is a very interesting trial. It's led out of Canada, that more or less is the answer to the Aruba trial. And TOBAS has been published, or a few iterations have been published. What I'm showing here is the registry arm for the patients that were operated on. And you can see that, there's over 1,000 patients enrolled, and they did an interesting design. They not only looked at the randomized patients, but also the patients that were not deemed suitable for randomization were kept in the trial in an observational arm. And they did 2 randomizations. If there was the decision to treat an AVM with curative treatment, the randomizations between curative treatment and observation. And in the second randomization stage, whether preoperatively or pre-interventional, pre-radiosurgery embolization, has any benefit. Now, the randomized controlled data from TOBAS have not been published yet, just the surgical registry patients. And the idea for TOBAS is to follow people up to 10 years. And here you can see the flowchart of those 1,010 patients. And here in this published study, we just look at the surgery patients. So we can't say anything about the observational patients yet. But what is interesting in those 139 patients, you see that about 1/5 was unruptured, the remainder were ruptured. And what I want to kind of get to is that the most of the morbidity in TOBAS, when you look at how those patients were managed, comes from the preoperative embolization. The resection numbers were very good, as you would expect with surgery, 90% obliteration. The higher or the lower the Spätzle-Martin, the greater the resection. So Spätzle-Martin grade 1 and 2, 95% obliteration. Of the ones that were very high grade, the rate of complete obliteration goes down. And about 50% of those patients were preoperatively embolized. And here you can see the morbidity. Severe adverse events occurred in about 21%. But what is very interesting that of the severe morbidity, 5 of 6 complications came from the preoperative embolization. So I think this leads me to the fact that surgery is often not what adds morbidity to AVM treatment. It's often the embolization part. So you should always think about whether preoperative embolization is really necessary. And I think this is where the hybrid cerebrovascular surgery concept really can be useful, because as the surgeon, you're the one who knows best which feeders are most difficult to access and where embolization may be most helpful to you for your surgical resection. How about recurrence of AVMs that have been treated? And what has been shown is that some AVMs do recur, and especially the risk of recurrence goes up when AVMs have been embolized. So when we embolize an AVM, and even if we resect it completely surgically, we generally recommend another angiogram around 3 years after treatment, just to make sure that there is no recurrence. What about treating AVMs with you can basically downgrade AVMs with SRS to make them more amenable to surgery. This is one of Michael Lawton's papers of 16 patients where he was able to downgrade previously, more or less considered inoperable AVMs by on average 1.5 points to then be able to operate those patients. And you can see those examples really nicely, how pre-SRS, they're very big, and then post-SRS, all of a sudden, they're very amenable to surgery, even though they have not been cured completely. So that's also a way to manage complex AVMs, is with downgrading through stereotactic radiosurgery. What about radiosurgery and embolization? This question whether preoperative embolization actually harms the likelihood radiosurgery will be successful. And at least in this paper, what was found is that it's not so much the embolization itself; it's more the complexity of the AVM itself that is predictive of the obliteration rate. So the more angiographically complex an AVM is, the less likely it is being cured with radiosurgery. Okay, and when we do a quick and dirty comparison, we can see that microsurgery or SRS plus microsurgery or embolization with microsurgery achieves very high obliteration rates. Embolization, at least from what has been published, is around 50% obliteration rate, similar to embolization plus SRS. And SRS alone achieves on average about 60 to 70% obliteration. Good. There's no AVM talk without talking about the Aruba study. Aruba was a randomized controlled trial looking at unruptured AVMs. And when I was a resident at Birmingham in Alabama, we were even part of the Aruba study, but it was very difficult to get people to enroll into Aruba. There was significant bias amongst surgeons whether the study was designed well, and not a lot of people were eager to enroll patients in Aruba. Aruba randomized between basically observation or medical management of epilepsy versus any kind of treatment, and treatment at the choice of the practitioner. And Aruba was published in 2014, and it's, as you know, well known that in Aruba, the patients that were treated with any kind of interventional management had a significantly higher risk of morbidity as compared to those that were just managed medically. Now, Aruba has been criticized for a number of reasons. Very heterogeneous group of unruptured AVMs. You can see that even though there were grade 4 and grade 3 AVMs that we know are from a risk perspective much different than lower grade AVMs. What was also interesting in Aruba was that the natural history was relatively benign. So the annual rupture rate was at 2% at the lower end of what we have seen in other studies. There was really a very high treatment or high utilization of embolization as the sole treatment. At around 30% of patients were treated with embolization only. And when we know that embolization is the main culprit for complications with AVM treatments, when we know that embolization only gets a cure rate of at best 50%, probably in most hands way less than that, it's clear that AVM embolization should, not steer AVM treatment in general. Only 5% of patients in Aruba were treated with surgery, even though 2/3 of patients had Spätzle-Martin grade 1 and 2 AVMs, which could have probably been treated with surgery. And at least for the US, how Aruba was set up, it was not really reflective of how AVMs are managed in most US centers. This triggered a whole bunch of papers looking at Aruba-eligible patients in individual case series. And this is one of Michael Lawton's papers, basically, which showed that in his hands, there was no difference between the Aruba-eligible patients that were treated with, with surgery versus those that were observed. Something similar has been done with Aruba-eligible patients in radiosurgery. And you can see here much better outcomes. Obviously, these are retrospective data, not a randomized controlled trial. But what this alludes to is that Aruba is not really reflective of how AVMs should be managed at a comprehensive cerebrovascular center. Now, did Aruba have any effect on how patients are managed? It may have had an effect, and this is an interesting paper that was published in 2022 from the National Inpatient Sample in the United States, which is a large administrative database of patients managed in the US. And what can you see? You see that there's the pre-Aruba period, 2009 to 2013, and 2014 to 2018. You can see that the endovascular approach only has decreased after Aruba publication. Not surprising after the bad outcomes in Aruba with embolization. You can see that the treatment of AVMs in general have decreased post-Aruba. And what you can see on those graphs, now I would caution you to take this with a grain of salt, is that the conservatively managed AVMs have definitely gone up with Aruba publication. The interventionally treated AVMs have stayed the same, or maybe maybe even declined a little bit. And what is also interesting is that at least on a population basis, there has been a higher or slightly higher number of total ruptured AVMs in the post-Aruba period. And you can really see this tip here in this axis, where up to Aruba, there's a slight increase year to year in the treatment of AVMs. And then with Aruba, the number of treatments have gone down. And, this basically shows, again, the risk of ischemic stroke and, maybe the discharge to a long-term care or in hospital deaths in conservatively managed AVMs from pre or post to pre-Aruba periods. A word on pediatric AVMs. So AVMs in children are a little different than they are in adults. Children present more commonly with ruptured AVMs. They tend to be deep-seated and cerebellar, and mortality from AVMs in children is higher than it is in adults. Children have less epilepsy. And there's really a very nice paper that I would recommend you take a look at. It's from Finland. It goes back, I think, back to the 1940s, and they compared the pediatric to the adult AVMs. And what they found is that in children, small nidus size is associated with better outcomes, lower Spätzle-Martin score, just like in adults. And those that were treated did better than those that were managed, that were not treated. Obviously, that's a selection bias in there, because those that were not managed probably weren't managed because they were too complex to manage. What was interesting is that the status of rupture in children did not have any association with outcome. And there's another nice paper from at the University of San Diego, and they found slightly different. They had slightly different results than what the Finnish group showed. They showed that the Spätzle-Martin grade was not correlated with the MRS at last follow-up, but they did find a correlation between ruptured and unruptured presentation. And in their cohort, AVMs that presented with a rupture had worse outcomes than those that presented unruptured. But in general, I think it's important to know that there's way fewer data on pediatric AVMs than there are on adults. And the group from San Diego basically presented this algorithm for pediatric AVMs that, from my point of view, is very similar to how you would treat AVMs in adults as well. If they come with a large hematoma, you try to resect or you try to evacuate the hematoma. And in terms of management, in lower grade lesions, you try surgery, and only higher grade lesions would be amendable for radiosurgery or combination treatments or observation. I think the main difference is that when you embolize AVMs, it can be long and tedious procedures with a high radiation dose, and you would be much more cautious in kids compared to adults when it comes to radiation exposure. There's a couple of interesting guidelines on the management of AVMs. Both were published in the Journal of Stroke. This ARISE consensus is pretty recent. I think it was published 2023. And it's a good resource on key aspects of AVM management. Now, what you will find is that there is very little solid recommendations on how AVMs should be managed. The most solid recommendation is that AVMs should be managed at centers that have expertise, that have all the necessary resources to manage AVMs. But in terms of which AVMs to be treated, these guidelines are very vague and don't give a whole lot of guidance. So in conclusion, I think from my point of view, surgery remains one of the mainstays of AVM treatment, even though it's not uniformly international standard anymore. Embolization should be used usually as a surgical adjunct. And remember that most morbidity in the management of AVMs, at least in the majority of centers, comes from the embolization. The surgery itself has less morbidity than the embolization. When you treat an AVM or when you decide to treat an AVM, it's always important to go in with a plan to treat it completely. I would be very, very cautious about partially embolizing an AVM. When you decide to treat it with the intention to cure and have a strategy ready on how to treat the AVM entirely. Like I said, when you embolize, since the morbidity comes from embolization often, I like to operate right away. I embolize and do surgery the next day, the same day, because I don't want to sit on a partially embolized AVM. The flow dynamics change through the AVM, and there's certainly some risk that comes when you partially treat an AVM. And I've not once seen a patient being embolized and then maybe deteriorating the night, overnight, or the next couple of days. So that's why I try not to delay surgery when I embolize. And for ruptured AVMs, I usually let them cool off, evacuate the hematoma if it's necessary, and then treat them in a semi-electric fashion when the clot has liquefied and you have a nice resection cavity through which you can access the AVM nidus. So with this, I'm going to close, and I thank you very much for your attention.
Thank you a lot, Dr. Christoph. It was amazing presentation. With different perspective of view, we saw about many things regarding the topic. Now, if any of you have questions regarding the topic or lecture, you can ask in the chat. I will read now the comments, what is in the chat, but also I want to ask some questions.
Before
okay.
Dr. Griessenauer, can you stop your screen sharing or not?
Yes.
Thank you.
Okay. I will read now the comments. Regards from Dr. Harshad Parekh from Mumbai, India. Okay, then what questions we have? Yes. Thank you for the conference where we learned incredibly valuable information. Until now, we thought it was very logical to operate the patient immediately after embolization. It would reduce bleeding, make the operation easier, and increase the patient's recovery rate. But after your talk, we saw that the realities of life do not always match the assumptions. Another thing, what we have. Yeah. Embolization is performed under general anesthesia. After embolization, the patient is usually taken to surgery without waking up. In this case, if there's a complication that harms the patient during embolization, we will not know about it, and all responsibility for the patient will fall on the shoulders of the surgeon performing the surgical resection. What do you think about this?
Yeah, this is a good point. We eliminate that problem by embolizing and resecting in the same person, because as hybrid neurosurgeons, we do the embolization and the resection. So when I have a complication of embolization, it's also my complication. But you are obviously correct. Now we do embolization obviously under general anesthesia, and then we go straight from the operating room. But in my, I would say, limited experience, in the time from finishing the embolization to opening the head and starting the AVM surgery, it's maybe sometimes half an hour or so. If the embolization has had no problems, then it's relatively unlikely that in that half hour something very terrible happens. But yeah, if you do it in one setting, you won't know whether you caused a complication. Now, if you're concerned, most new angio suites can allow you to do a dyna CT, so you could look whether there's any bleeding event, ischemic events you would usually see on the angiogram anyway. But yeah, that's why I'm a fan of the hybrid model, because you can basically apply both techniques.
Okay, thank you a lot. So other question is about GR4 and deep arteriovenous malformation can be treated with stereotactic radiosurgery. What is a result of complete obliteration? Here is the question.
Yeah, that's certainly a challenge. I mean, like I said earlier, you can either treat it with volume or dose staging, but the obliteration rates are, poor. They're somewhere between 30 and 40%. Now, I remember one distinct AVM in my residency. It was huge AVM that involved the entire brainstem cerebellum, and we radiated it, and after a few years, it was gone. So I mean, sometimes for, deep-seated AVMs in the basal ganglia or in the brainstem, you really don't have any other option but to do radiosurgery or any kind of radiation. I mean, they're not amenable for surgery. They're often not amenable to embolization. So there's no other option but to do radiosurgery.
Okay, thank you. I have questions from my side as well. If anyone wants to ask, you can ask. Otherwise, I will ask. And I will take your time now.
Want to talk? We can. Mariam, Professor Yunus Aydın raised his hand.
So you can unmute him, maybe.
Yes, I did.
Yeah. Thank you. Very nice talk. Congratulations, doctor. The best message which I got, embolizations, complications, more than the surgery. Just, I want to say as an experience, I did more than 400 cases without embolization because I served in the state hospital. At the beginning, we don't have the facility of the embolization, but that's why I didn't use. One question, because the doctor is hybrid surgeon, which I liked. In future, all procedures should be done by the hybrid surgeons. If in one case you embolize, and technically after DCA control is totally occluded, what's your choice? Resection or follow-up?
Yeah, that's a very good question, and congratulations to your experience. That it's yours is much bigger than mine.
Sure.
But we generally, when we embolize, we don't embolize with the intention to cure the AVM. We more or less embolize with the intention to make the surgery easier. Now, sometimes when you have a small AVM, we don't generally embolize anyway. So we embolize ones that are bigger, that we think are more manageable if they're partially embolized. Now, I've seen sometimes cases where embolization goes so well that after embolization, the AVM is completely gone. In those cases, then we decided to not do surgery. But I've also seen at least one case like that we thought it was gone, and then on follow-up angiograms years later, it was refilling, and then we would operate at that time. But to answer your question, if I saw it was completely gone and there was no AV shunting, then I would probably not take the patient for surgery, would just leave it at embolization.
But embolization is not first-line treatment for you.
No, absolutely.
Yeah, absolutely. That's actually it was a hidden criticization because some not hybrid surgeons, interventionalists, radiologists, they are doing this thing, only embolization and send the patient home. And sometimes I see the remnants, but they decided to go home and they don't refer to the surgeon to patient to the surgeon. That's why it's good. You are doing both things. You're neutral for decision making. So I agree with you. AVM should be totally resected. Should be resected. Embolization I didn't use, and sometimes some surgeons say that with the embolized patients we have a heart part, especially the deep part. You cannot eliminate. You cannot reach the other parts because the stuck part prevents the access. The embolized part. Yeah.
I think you're totally. See, for me, it's just very difficult to predict whether embolization is going to cure an AVM. In my experience, I can more or less, in most cases, I cannot cure the AVM with embolization. So if I start embolizing an AVM without a surgical strategy, in most instances, I will be left with a partially occluded AVM that is probably more dangerous than the AVM that I started with. So that's why I would highly advise against doing partial embolization in hopes that you can get it occluded. I think if you do that, then you need to at least have a surgeon nearby and on board that can then take care of the AVM if it doesn't work out. But you cannot really, in my opinion, you cannot predict whether embolization is curative ahead of time.
But
with surgery, with surgery, I get a good sense whether an AVM can be operated.
But, actually, my comment is for the take-home message for our young colleagues. Embolization is not enough, and so I see sometimes lonely embolization by the neuroradiologist without any neurosurgical surgeon present. Thank you very much. Congratulations.
Thank you.
Okay, bye.
I will continue the comments. Thank you, sir. It was a great lecture, great talk. This was Dr. Nurullah Kızmen, Turkey. Then Ayman Maidan is writing, thank you. What is your experience with preoperative seizure on follow-up?
So if we think that the AVM caused the seizures, and if their seizures then stop after AVM removal and the AVM is completely gone, I usually keep them on anti-seizure medications for another 6 months or a year. Then I do routine EEG to look for any interictal spikes. But if the AVM is completely gone and they have not had any more seizures, then I will eventually wean them off anti-epileptic medications.
Okay, thank you for answers. I have questions from my side.
Sorry, but Andrei is with us now from Ukraine. I want to hear from him also if he is available.
Yes. Hello.
Andrei,
Hello.
welcome.
Yeah, nice to see you. Yes, I'm here. Do you hear me?
Yes.
I'm driving home. Have no good video. Sorry. Thank you for all. Slava, Heroям Slava. Thank you for very comprehensive lecture. And I have one question. What's the timing of embolization in case of ruptured AVM?
I didn't hear the entire question.
What is the time of the embolization or surgery for the ruptured AVM? Andrei, can you repeat, please? We cannot hear.
What is the best timing for embolization after the bleeding? Do you wait some time or proceed immediately?
So if it's a, let's say it's an AVM that had a high risk feature like a feeding vessel aneurysm that caused the rupture, then we would treat the aneurysm immediately. We would only do embolization in preparation for surgery. So let's say we have an AVM that caused the intracerebral hemorrhage. The hemorrhage was evacuated or didn't even need evacuation. And then we would decide to operate the AVM 4 weeks later. then we would embolize if we needed to and resect in one session. But I also don't like to partially embolize recently ruptured AVMs without an intention to cure them right away. So it's basically the same principle on ruptured or unruptured AVMs. Embolization should be done right before surgery, just to make surgery easier, but not to prevent or protect the patient, because I don't think partial embolization protects the patient in any way.
Okay, so thank you.
Thank you. Mariam?
I have questions regarding the genetics and molecular staging. So my first question, 1 minute, I have written down. Yes. I'm interested in what you think about preventing AVM formation at the genetic level, or you think it's better to regulate those stuff on post-formation therapeutic approaches. I have another question as well. What you think about molecular imaging? Do you think if this molecular imaging have a really good future in the future, in medical future, or do you think this angiography won't be, replaceable?
Well, I think as long as we manage AVMs the way we currently do, then angiography remains the gold standard. It's not just angiography, it's usually supplemented with MRI just to help to decide eloquence. We do, advanced imaging like DTI, diffusion tensor imaging, to look how close it is to, tracks. We have even done transcranial magnetic stimulation to look whether an AVM is an eloquent location. I'm not really sure what molecular imaging here would exactly entail, but it's not something that I'm aware of that's relevant in AVM diagnostics at the moment. And in terms of, mutations, we are really in the early stages here. We find, these KRAS mutations in a number of AVMs, but it's not in any way clear if we can use that mutation in a way that we can modify, the course of the AVM. Potentially for facial AVMs, like I've shown with this KRAS inhibitor, but I'm not aware of any medical treatment for brain AVMs at this point. So I think it's more of a pathogenesis stage, but we're not really in a stage where we can have a medical treatment for AVMs around the corner. We consider AVMs generally a disease that we're born with, but we almost never find AVMs in newborns, or we don't see them on prenatal ultrasound. So even though we probably carry that mutation in ourselves, the AVM, develops at some point during our, childhood, maybe early adulthood. It's not something that we are, born with, essentially. Maybe we are carrying that mutation, but it's not that the AVM shows up right at birth. It can come way later. And there's a number of case reports, and we have had our own case reports, even in adults, where people have had totally normal MRIs and CTs a few years before, and then a few years later, they have an AVM in a location that was completely normal before. So it's not really a congenital disease per se.
Okay, thank you. So mostly you are supporting surgical interventions, I guess, regarding the arteriovenous malformations, because as it is associated with also inflammation, maybe treatment and therapies, management with anti-inflammatory drugs can be also helpful. But as you are mostly concentrated on surgical interventions, I won't ask those questions because I had those. So I think I will dip into such kind of things. I will read more. So thanks a lot. If anyone has questions or comments, you are free to ask. Bektas, Dr. Bektas, you want to comment on anything?
Dr. Bektas Açıkgöz. You can turn on your microphone. Okay.
Thank you very much, Professor. Thank you very much. It's a very didactic lecture. And I personally thank you very much for staying in the surgical side. Thank you very much.
Thank you for your nice comment.
Okay, I will give now place to Madonna Khobadze, who is Georgian neurosurgeon woman.
Okay. There are some young
Madonna,
with
are you
us
here?
now. Madonna.
Good evening, good morning, wherever you are, Professor. Thank you for a insightful and great lecture. I wanted just to express my gratitude. I have no questions. It was straightforward and discussion part was very nice. So thank you for sharing your experience and insights.
Yes, today is
By the way, it's a Christmas Eve in Georgia, so
evening for Georgia.
Merry Christmas.
Merry Christmas.
Thank you.
Okay.
Dr. Ertan, do you want to comment on anything?
I think Ertan is not available.
I will be a little bit subjective, and I want to give talk to
Selin
Dr. Ertan.
is here with us, young woman neurosurgeon from Turkey, but she is in the United States now.
Wow.
Selin or Efecan. Okay, I think they are not available. So, as we finished all the questions and comments.
Yes.
Can you hear me?
Yes.
Good.
Okay.
Sir, thank you for your great lecture. We learned a lot from this lecture. Thank you for Professor Suju for this really great organization. Thank you.
You learned a lot. Yes. Thank you so much.
Thank you, everyone. I think this session was amazing. Thank you, Professor Christoph, for your contribution. Thank you, Dr. Hassan. And thank you, all of the guests and all of the people who we are listening to us. And thank you, of course, me.
And Merry Christmas. Merry Christmas, all the people in
thank you.
Georgia, Ukraine, also for Andrew, I think, Christmas night. And
don't drink so much. Don't drink so much.
Mariam will go to sing in the church after.
Yes, now I'm going. So please go fast. I am going. I'm in rush.
Okay.
Thank you very much.
Bye.
Bis bald.
Bis bald wieder.